Hello and welcome to this webinar on liver injuries, which is brought to you by ESTES, the European Society for Trauma and Emergency Surgery, in collaboration with the EATSIG, the International Association for Trauma Surgery and Intensive Care. This webinar will be based around a number of challenging cases with a combination of interactive polls, in which I hope you'll take part, as well as a panel discussion. Your responses will be completely anonymous, unlike those of the panelists. So I'm going to hand over now to Tina Garda to introduce the session and the panelists to you. Tina.
Hi, good evening, and I'm really looking forward to this webinar on liver injuries. The thought behind it was that I think there's been not that much written about liver injuries over the last few years, because it's sort of sorted out the way we treat liver injuries. Blunt injuries, if they are stable enough, they can go to CT scan. Most of them have stopped bleeding. They can be managed non-operatively. Penetrating injuries get operated, and so on and so forth. But there are some, we've gathered a couple of cases that we want to challenge the panel and the audience, where maybe the course wasn't that straightforward and posed some challenges. And we also want you to take some messages back home after the session. We'll see how many cases we are able to go through over the time, and Jonathan is probably going to stop us at the end. I want all the panelists to introduce themselves, so I'll start the way I see them on the screen. Jonathan has already, well, actually, you can introduce yourself, Jonathan. You're also part of the panel.
I hardly ever introduce myself. I'm Jonathan Tilstead. I am a general surgeon from Hull in the UK.
Hayato.
Hello, hi to everybody. My name is Hayato Kurihara. I'm a general surgeon, emergency general, and dealing with trauma patient also in Milan, Italy.
Christina.
Hi, everybody. I'm Christina Rey. I'm a general surgeon working in an emergency and trauma unit in Madrid, Spain. Nice to meet you.
Paul.
Hi, Paul Axelness, pediatric and trauma surgeon working together with Tina in Oslo, Norway.
Shaheen.
Good evening, everyone. My name is Shaheen, and I'm a trauma and emergency surgeon working in Sweden, Örebro.
Vicky.
Good evening, everyone. I'm Vicky Jennings. I'm a trauma surgeon that works in South Africa in Baragwanath Hospital and at Netcare Mill Park Hospital.
Then we'll just go and move forward with the cases, and we'll see if we can challenge them later. Okay, I will start sharing my screen, I think. Do you see my slide?
Yes, we see your slide, Tina.
See the slide. Yeah. Fine. I will start straight out with the first case, if I am able to make it move forward. Yes. So this first case is a 48-year-old man. He has been out drinking. He is sort of drug addict. I think what we know from the information that he has also taken some heroin. He was in a fight and got stabbed and kicked. His missed handover states that he had stab wounds to the head, chest, abdomen, and blunt injury to his head. He is drowsy, cool, and clammy with a systolic blood pressure of 100. He got one IV line. He got some blood products on the way, some plasma and red blood cells, and 1 gram of TXA. So I'll move you straight over to the primary survey before I ask for some feedback from the panel. So he is awake when he arrives. He does not have a neck collar. Trachea is midline. He had a stab to his left cheek that's actually bleeding. So it's like a Joker injury. So his mouth is split on the side and it's bleeding into his mouth. His breath sounds are equal, SATs 100 without oxygen. He has respiratory rate of 20, dry skin, cool, periphery with systolic blood pressure 108, pulse rate of 75, pulses palpable also peripherally, GCS of 14, moves all four extremities. And what they find when they look at the whole body is that he has a stab wound to his left cheek that I already described. He has also one left midclavicular at the 5th intercostal space. And then he had one right mid-axillary in the 10th intercostal space on the right side. So what would you think? How would you go about with this patient? He's not too agitated, but he is bleeding into his mouth. We have made a poll question for the audience. So the panel is not allowed to vote. You can just think out your answer. We'll see what the audience, everybody who's logged on, if they want to answer. So X-ray, chest tube directly on the left side, intubation, start resuscitation with ongoing blood products, CT scan, operating room. What would be your thought? We know it's difficult to have one choice only. This is just to start the discussion a little bit. That's well spread. That's good. That's well spread out. So most would have an X-ray or a CT scan, probably depending on his whatever. And then a little bit, so chest tube, intubation, resuscitate. There's a little bit for every option. So I will start with Vicky. What would you do? This guy in South Africa.
Yeah, so in South Africa, and I know in Sweden, it seems that it's actually more difficult to get a chest X-ray than it is to get a CT scan. But what I would do in my circumstances, we do an immediate chest X-ray and we would follow that with a fast to assess for any intra-abdominal bleeding. I don't feel there's a place for intubation right now. He doesn't seem to have an airway issue. And in between that, you can still resuscitate him.
I ask a question, Tina. Hi, Vicky. If you're going to do the fast, why are you doing this chest X-ray? Why don't you just do the e-fast or faster?
Actually, we do both. So
why? The ultrasound is reliable.
Yes, it is, but it's also operator dependent. So it depends on who your operator is. And in my circumstances, we teach and train many, many levels of doctors. So they do not always, the easiest thing to sometimes miss is lung slide. Our equipment is also not always 100% perfect. So we take a bit of a more global approach to it. If my chest X-ray was going to take long, or if it was going to decompensate with it, I wouldn't hesitate to place a ICU drain, an intercostal drain, or a chest tube by any means, waiting for fast or otherwise.
So far, what you have said is actually that what you do depends on your institutional capabilities. And I think the most important thing is actually that you have an algorithm for these cases in your institution, which actually are effective so that you don't miss any obvious injuries that you should actually be capable of dealing with within a short time. So if X-rays are easily available, that's good. If you have the capability of doing an e-fast and you know that the operators are skilled, then you can do that. But again, just have one algorithm that you follow, so you don't actually have to stand making the discussion whether you should do this or that.
There's another thing that I would have done in South Africa that I know internationally no one else has access to. It's called a low dox. So before he hit our resuscitation room, he would have gone through the low dox, which is a full body low dose X-ray as screening. And based on his current vital signs and parameters, he would have been a candidate. So our patients often run through the low dox first, which already gives us the chest X-ray part of it before they go into the BAME.
If I ask you then, this patient, if you have a normal X-ray with a stab chest, stab abdomen, and that's basically it, would the low dose give you more than a normal X-ray?
No, it just creates the ability for us not to ask at all for a subsequent X-ray, and immediately we use it, especially in penetrating trauma when we have multiple gunshots, because it gives you a better idea if you place bullet markers on it, where your potential trajectories are, what you want to do for that patient.
Yeah, no, I agree. I mean, that's where it really makes a big difference. So, any other comments at the moment?
Now, I think this is up to the setting of your hospital. In that case, I would personally go with EFAST. And then probably I would have anyway a chest X-ray, but probably I could have a chest X-ray especially to check my chest tube if I needed it. And no Lodox, since we do not have diamonds in Italy.
So if you do an EFAST and you see a little bit of fluid in the chest, and that's it, would you put a chest tube at the moment? This guy is holding there, doesn't need a lot of, and so would that make a difference if he has a little bit of fluid?
Just some fluid. I will put a chest tube if I see a pneumothorax, just some fluid. Probably I would not lose that time because this guy probably has to go to the OR anyway, and it would take 5 or 6 minutes to get a chest tube.
Okay. Do you want anyone wants? I'm a blood gas fetishist. Do you want a arterial blood gas?
Oh yes.
Yeah. Any other comments? I will give you. Wait. I will give you his blood gas. He has hemoglobin of 13. He's doing fine apart from his lactate is 4.4, which is probably not very surprising at the moment. Okay. He got actually by that time he had 4 units of FFP1 RBC. He's doing fine now. I mean,
I just want to ask Vicky, do you want, based on the information, including the blood gas, would you have started with transfusion in that patient in South Africa?
No, sorry, I was just Googling kilopascals into milliliters mercury to make sure that I have the figures correct. So if I read this blood gas correctly in a South African version, hemoglobin's a concentration dependent. It doesn't really give you much of an idea other than a trend. His pH is holding, his PCO2 is normal, his PaO2 is above normal, his lactate's high. I wouldn't have transfused him yet because A, we don't have products, and B, he doesn't quite fit the criteria currently.
Exactly.
But they were a bit worried at the moment in the beginning because they were stressed when they get this patient in, and he was not doing that well. He was tachycardic, and he was 100 systolic and so on. So that's why they started. I agree. He got too much blood products at the time. But after those blood products, he's doing fine. He's awake, but he's bleeding arterially from his so they had to compress his wound at the cheek level. Would this be a candidate for CT scan? I mean, his fast, they couldn't see any free fluid in his abdomen.
Even in the pericardium, no free fluid in the pericardium.
No
Negative
pericardium.
Yeah.
And he's doing fine. So physiologically, he's doing fine now. Would you do a CT scan?
Yes.
Definitely.
Yes.
Okay. Not take him straight to the OR. I mean,
No, not the moment. Probably
No.
depends on your setting, but most of us go to the CT.
if you have
I
a
would
CT
control the bleed in his face before the CT scan.
Yeah. No, that was compressed. So his bleed in his face was compressed. But they were worried about this bleeding and how deep this was, and he wasn't that well cooperative. So they actually decided to intubate him before they took him to CT scan. He would tolerate an intubation, but that can also be discussed. I agree. I mean, if he is cooperative with control of that bleeding, that should be okay. But they were worried about the bleeding.
Actually, there was a question from the audience that was asking, really intubation before CT, which is actually what. So no one of the panelists would intubate this patient at this moment, right?
If he's bleeding,
Was the concern about protecting the airway while you intubated the patient?
So the concern. First of all, we know from his physical exam where they explored with the backside of a vent on the tip that the abdominal wound is actually going into his abdomen. So it's a penetrating wound. It is going into his abdomen. There's no free fluid of any that they could see by a FAST. So they knew that this patient was going to be taken to the OR. He's going to have a laparotomy anyway. And the issue was that he wasn't that cooperative, and they were a little bit sort of worried about taking him through a CT scan without, and if they're going to have a laparotomy anyway, that he could be intubated. His physiology tolerated it, so they decided to intubate him before the CT scan, where they have less control of the patient based on that. Any comments on that?
Yeah, if I can jump in, there are a couple of things. The first thing I would do in that ED when he rolls in, I would take that neck collar off. I don't understand why they put a neck collar on somebody
He did not have a neck collar. No neck collar.
Okay. No neck collar. Then the question is about the FAST exam, and this is when people can not decide if they're going to stand on the right foot, left foot, or on both foot. The most important thing with the FAST is the cardiac window. I don't care if they see anything in abdomen or not. It doesn't change my management at all. So if it shows a little bit blood, he's totally stable, he goes to CT. And if it shows a lot of fluid, or a little fluid and he's unstable, he's going to go to OR.
So this FAST was done and the pericardial window was negative.
Exactly. So if you have people in the OR that do FAST that you rely on for the cardiac window, you should rely on those same people to see lung sliding, which is actually kind of easier to see than pericardial fluid. So this patient is totally stable. He should be at least permissive hypotensive. We give him a lot of fluid, and then we are asking if we're going to intubate him, which would make the opposite of keeping his blood pressure up. So we are trying to do everything to have this patient severely hypotensive now, giving him a lot of fluid against the permissive hypotension, and then putting him on all this medication for intubation, and then go with him to CT.
We agree on that. So Shaheen, we agree on that. The point was not to take his blood pressure was not taken up. He was seen as not stable enough. He had a lactate that was high, and he needed some resuscitation, and they chose to put, because they didn't know enough about him, they chose to give blood products. We totally agree that if you're in a place where you don't have the access to blood products, but they saw him as more unstable. They did not pull up his blood pressure with blood products. The question whether you would intubate or not a patient, would any of you, if you want to discuss social indications for intubation, if you decide that this patient needs a CT scan. So if you see this now, you have a FAST that's negative for his pericardium, you have this chest X-ray, and you have a FAST plus minus. I agree, FAST doesn't give me anything in this situation, but you have a penetrating abdominal injury. Do you guys want a CT scan before you take them to the OR?
Definitely, because even with the penetrating at liver, if you have the CT there and it's arterial bleeding, if you have a hybrid room, you can coil that. You don't need to
Exactly, Shaheen, and that's the point. You want the CT scan, and this patient could have a sort of an indication, because he is not cooperative enough. The team felt more secure, and they saw him after initial resuscitation as stable enough to tolerate that intubation, and they knew he was going to go to the OR anyway, and he would need an intubation. Vicky.
Yes, I would say I've been in that situation, and we do see it quite often. Our patients do arrive intoxicated. They are belligerent. They're combative. It's extremely difficult to ascertain whether or not you have an associated head injury with someone that's assaulted, or they're purely belligerent because they are intoxicated. If this patient doesn't have an acute indication for a laparotomy or for thoracotomy or sternotomy, whatever the operative procedure might be, getting a CT scan for him would be highly advised, or I would do a CT scan for him. And if that requires intubation and ruling out a head injury at the same time that I'm scanning his abdomen, I would proceed to do as such. You don't know why this patient is so confused or why required to be intubated.
We know that patients who need, if they go straight to OR, we want to wait with intubation until we are in the OR. But this is not the case physiologically with this patient. Anyway, I'll give you the CT scan because we have 5 cases. We are going to move a little bit. So this is the first of a few slides. You see the tract through his liver. Obviously, the theme here is the liver injuries. So yeah, I know you expected the liver injury. It goes through his right lobe of liver. There is not that much, obviously there was not much blood and there was nothing in the pelvis. And this is where you see it goes through his lower part of if you see this, this last slide. So no free air, nothing else to be seen intra-abdominally.
And the duodenum looked okay?
Say again?
The duodenum was okay?
Didn't see anything abnormal close to the duodenum or the pancreatic head or anything there. No, looked completely normal.
And no arterial extravasation.
Nope. Nope. So is this a non-operative stab abdomen?
I would say definitely no, at least in our part of the world, because we see relatively few of those. And of course, although you don't see any free air within his abdomen, of course, he can have a laceration to his small bowel, for instance. So our algorithm is that he should undergo a laparotomy.
So can I ask again? So sorry to use you, Vicky, but Grotteskuur they have published a lot on non-operative management of liver injuries, gunshots, or stabs. Would you be happy with this one non-operatively managed? You see the tract all through his liver.
So the one thing that does worry me, so I can't, obviously we don't have all the slices. I can't nicely see whether there is a blush or not. It doesn't seem to be in active contrast extravasation. There's no free air. The only thing that's concerning me is that I cannot see where the tract ends nicely on the slices. So I would be concerned that there's injury that we can potentially miss in this patient. If I reviewed all the slices properly with a radiologist or in conjunction with it, I could see where the tract ended, and I was sure that there's no other indication for laparotomy. In this patient, I would have treated him conservatively.
And that is, I think, the difference between the South African setting, where you have that amount and more shortage of operative capacity. And possibility and knowing the signs if patient is deteriorating and so on and so forth. If you see the tract here, it actually goes all the way through and towards the hilum, and you cannot see that it stops within the liver. And that is why it was absolutely not an option in our setting. And I would still say, as Paul was saying, that in the European setting with very, very much less penetrating, very careful about the non-operative management. Okay, so this CT scan, in addition to the liver injury that you saw, showed an occipital fracture. So he had been kicked in his head as well. Moderate subcutaneous emphysema on the left chest, up to neck. No pneumo or hemothorax. There was a rib fracture, the 11th rib on the left side, but no vascular pathology, including the neck. And so that was the CT scan. I think we discussed that already. So he's taken to the operating room, and he's so go through. I assume that everybody's going to do a laparotomy and no laparoscopy.
Sorry, I actually wouldn't do a laparotomy if I got this case right. This is cirrhotic alcoholic patient.
Well, like he was drunk. He was drunk, but you don't know.
He was just drunk. Okay, I thought you said he was like.
Oh, no, it was not a cirrhotic liver.
Okay, then.
It was maybe a drug addict.
It was heroin in the history.
So at least in my hands, I would, instead of giving him the big scar, I would probably look into his abdomen with a laparoscope to just see if there is any indication of small bowel injury or duodenal injury, and see if he can follow his exams afterwards.
Well, can I challenge that? I think that your possibility for most, even if you're a good laparoscopist, to be able to completely rule out any a small stab wound to the bowels that early, just after the injury, I actually don't think you're able to. So
Yeah,
that
definitely.
you introduce air and pain with the laparoscope. I would not do that. If you decide, I mean, then I would rather say, okay, observe and observe him clinically, wake him up and observe him clinically. That would be an option. But in our situation, the way we saw that tracked through the liver, we decided that this is an operative case. Also because of his head injury and everything else. Just rule it out. Don't make the problem bigger. Or
may I add something, Tina?
Sure.
In that case, it's not clear where the stab wound was exactly from the abdomen, but I would like, even if it's on the right side, I would like to rule out also potential diaphragmatic injury.
Sure.
In such a patient.
So if you see there, you see this, oops. You see the stab, you see a little bit of the reaction in the subcutaneous fat on the side. You don't exactly see where the wound is, but it is very close to that area. Do you see my arrow?
Yeah.
Okay, so it's between, so in 10th intercostal space, more or less. So yeah, you could probably also be a diaphragmatic injury as well. I think, no, you don't see much there. Okay. Anyway, so chest tube on the left side or just observe? Vicky, you have your hand up?
Oh, sorry, just to spice it up a little bit.
Sure.
Even if we were investigating for diaphragmatic injury from a penetrating stab wound, that would have likely to have a relative small diaphragmatic injury if it's on the right side. Even if there's a diaphragmatic injury, we wouldn't operate on it. We wouldn't repair it because the liver tends to splint it, not herniate.
We'll come back to
a very controversial subject for many people,
yeah.
I realize.
Yeah.
But I think we will come back to another case with exactly the same. And I agree with you on the right side, but we'll come back to that. This is very low on the right side and almost lower than the liver. So, I mean, it's a thought and we need to think about the diaphragm. I agree. Anyway, so he was operated on. There wasn't anything else to find. So everything else was fine. There was no ongoing bleeding. I mean, a very, very slight ooze, but almost really nothing. Systematic assessment, no other injuries, washout, and an active drain was left in the Morrison's pouch and then closed. Okay, so what happened after that on day one? I mean, he got an epidural. He was well. Vicky, you have your hand up?
My apologies, I never lowered it.
That's fine. Okay.
Yeah, may I ask a question? When they did the laparotomy, did they do a total kosher and looked at the all the way?
I agree. So that's an important point. Absolutely, when you go in, and that is one of the reasons why you actually should do a laparotomy is to do a full cauterization because of the way this came through. And there wasn't a small wound on the hilar side of the liver. So you definitely need to rule out that there's anything. Okay, so no ongoing bleeding, systematic assessment, active drain, I said that. And then, so he got his epidural. Trauma prophylaxis was started immediately after with 5. We use aggressive trauma prophylaxis. So adult men larger than me get 5,000 twice. And we think that is irrelevant for at least for blunt injury. Blunt injury is more important than penetrating. And this guy has sort of risk with drugs and everything else on top of it. He was sent to the surgical ward, but then suddenly on day 3, the drain was left for bile leak. But suddenly he starts, blood comes out on his drain, 1.2 liters. And his hemoglobin is falling to 7.6. He's pale. The systolic blood pressure is holding, but they got worried and they saw the hemoglobin, so they gave him a unit of red blood cells. Now what?
CT.
Say again?
Yeah, arterial and embolize. Yeah, it seems like an aneurysm rupture.
Okay. Do we want? We'll let the audience of the ones who are connected now answer the question. Do we want to take him straight to the OR and open him again, a CT scan, or an angio? I mean, his physiology tolerates any of the options, basically.
My question is, do you have interventional radiologists that would accept to go directly to angio?
We don't.
Me too.
But I think actually this guy, because we had a CT scan when he came in, they would have accepted if we said he's coming. They would do it. What about the rest of you?
For me, will be okay. My radiologist will go on with the angio and embolize if in case.
Without CT scan, that would go directly. Okay.
If we ask for it, they will do it. Yeah.
But Christina, can we ask you? So if the patient came in without this, if you never had a CT scan before, so the patient comes in with a pelvic injury, for example, would they accept doing interventional radiology without a CT scan?
Sometimes yes, and also it is in our protocol. But okay, I'm talking in this setting in the third day after the surgery. If it's a patient coming in with a pelvic fracture and with a negative FAST, and we really think that the source of bleeding is the pelvis and is crashing down, we can't resuscitate him, they will accept to go through the angio before the CT scan. Yeah.
Mm-hmm.
But in this patient, you know that the bleeding is in the abdomen. The patient has actually already been through a laparotomy, and you have ruled out other sources for bleeding than the liver.
Mm-hmm. We know where the problem is.
Yes. So angio is definitely very indicated.
So CT scan.
There was a question from the audience. It was blood from the drain, not bile. Right.
No, so actually the hemoglobin on the content on the drain was 7.6.
Okay.
So yes, blood. It was definitely.
Also, sorry, but also you can face the same scenario without blood from the drain. You can see an hemophilia just with the patient crush, and it's the same way, and you don't see anything through the drainage.
And that's a very important point you make there. I think the fact that we should never trust the drain to tell us if the patient is bleeding or not. This time is the first time I think that we actually had all the blood coming out on the drain. Not ever.
Lucky him.
Lucky, yeah. Okay. Anyway, we would have. So the point was, his physiology changed anyway. So he was suspected of having a bleeding. The fact that it came out on the drain was an additional aid. Now you have your hand up, Vicky. Is that an old hand too?
So strangely enough, I would have done two different things in the two different hospitals that I work at. Mm-hmm. If this patient was drained suddenly 1,200 mils in my ward at Baragwanath Hospital, I would run with him to theatre.
Yep.
I'd go pack him. We don't always have TIGs. If we did have a TIG, I would do a TIG. I would cell save that blood and I would retransfuse them to him, and then I would cross my fingers and I hope that we can find some source of bleeding.
Yeah.
If I was in a level 1 unit where I have angio embolization 24 hours a day and I can resuscitate within my angio suite, I would have gone with him to either the angio suite or the hybrid theatre, one of those places where I can do a combined approach.
Yep. So And again, so this guy could have been taken to CT scan or to angio. They chose to take him back to a CT scan before, while they were waiting, because our interventional radiologists take 30 minutes anyway to be activated 24/7. And they want to, like what's commented already, they prefer to have a CT scan to see what they're looking for. This is what you just get 3 of these. So they have it's actually a large subcapsular hematoma. And if you look at this slide, this is the original part of the original stab tract through the liver. There you have the pseudoaneurysm. There you have extravasation in the original channel. And it had bled out. no actually bleeding, and there's no. So everything, all that came out of that subcapsular hematoma actually came out on the drain. There was nothing in his pelvis. Okay, so now he was taken to angiography, obviously then. And they found, so it's actually the best. I couldn't find better pictures of it, but they had there is the pseudoaneurysm is there, and there is so slight blushes 2 or 3 places, and they were coiled, the branches of the right hepatic artery. So his drain was removed on day 9, and then he had fever, increased CRP. The drain had been removed, but they actually, from the drain tip, they grew Staphylococcus aureus. He got antibiotics, and he was discharged feeling fine on day 13. Okay, we were not unlikely to have any kind of follow-up with him. But then day 5 after discharge, and this is just the more surprising part of that, he's admitted to the local hospital with a massive stroke. He had fragment until he left. I think only there was one dose was stopped during his hospital stay when he was with the epidural was taken out. He had, yes, you see the CT scan there. There is a massive thrombus in his left internal carotid. There is no. We've been going through, and this was just by chance, basically, because I was looking at the case that I came back and I saw he was admitted in another hospital, and they had contacted neurology and neurosurgery, and he has like as you see on the head CT, this was beyond any kind of active treatment of his thrombus at the time of admission. He's now in rehab, and there is really, we've gone back through all the vascular. None of the stabs were close to anything on that side. Yeah, and probably. So, Vicky, you want to comment? If anyone comes up with a very, very plausible explanation for this, apart from
that would be exactly my question: is how far was the stab on his left cheek away from this internal carotid artery? And did we definitively exclude that there was no vascular injury or close to that vessels from the beginning?
There was an angiography all the way up, and there was nothing, because it actually, because of that paranoia that was looked at, and we went back and looked at it again when we saw this, and that was the only thing associated with this injury that could have explained it. We could not find any other. Opened something between left and right heart or something that could have explained that it came from somewhere to the other side. So this is just very sad. And when we've gone through it again, we cannot find a good association, apart from the fact that he might have gone out and drugged himself again on heroin, and this comes from something completely not associated with the injury.
And Tina, can I ask you one very strange question? But on his initial imaging, there was we never re-looked or reviewed whether or not there were any vegetations on his cardiac valves, or with regards to his cardiac status that maybe from being a drug addict, he actually had vegetation. So he grew a Staph aureus. He might have had it from the beginning.
But again, there was nothing in his course until then. And would you do that with every stab patient coming in? Even though that's
just to go look back and see. I'd probably go look at the scan again and just go see if there's any way that I could see something different, or because on a fast you're not going to look at the valves. That's not your aim. I would look at the CT scan just to, I don't know, for lack of anything better to do with my time. Go look at these parts.
We're gonna looked at everything, and we couldn't see anything on those. The CT scan wasn't made for this purpose. So we couldn't see anything that can explain it. Anyway, that was surprising and sad end of that story, basically.
Scan his neck on his original CT, or was it just head, thorax?
No, it was a CT angio of his neck all the way up, just because of the proximity of the stabs in the face and so on, and and his kick, the back, and his occipital fracture and everything else. So it was done with the full CT angio all the way up. Nothing.
The other question that's been asked, Tina, is do you routinely send the tips of your drains for culture?
No, but I think he was already a little bit higher on when the drain was taken out. He was a little bit higher he was increasing in his CRP and so on. So it was no, not normally. No, we take them out. I have to admit that. Okay, so let's jump to the next. This one is a completely different history. Case 30-year-old woman. She has known sort of reflux and she's on contraceptive pills. She has a history of 3 days of pain in the left calf and dyspnea, actually. And then she calls, the doctor is called, the pre-hospital personnel is arriving, and she actually gets witness cardiac arrest while the pre-hospital personnel is present at home. So anyone want to comment on what would have been done? We know we don't have pre-hospital personnel in the panel. Anyone wants to comment on it? Apart from the normal approach CPR of a cardiac arrest. In this situation, what do you think, what are the differential diagnoses in a 30-year-old woman with witness cardiac arrest? What would you think?
With that history,
pulmonary embolism.
She has a pulmonary embolism, right?
yeah,
That's what we'd expect.
So a massive pulmonary embolism. The other things that could make, could give a cardiac arrest would obviously be cardiac. Thing. So what would you expect to be done pre-hospitally in a situation like that, apart from the CPR and normal approach?
Yeah, maybe thrombolytic.
Mm-hmm. Yeah.
Does someone did any fast and cardiac views of ultrasound?
Exactly. That's a very good point. She got an ultrasound of her heart and she had a dilated right ventricle. So
then you have to tell them that actually it was an anesthesiologist present on scene. Yeah, it's
so
not
this is
paramedics.
Yeah. You can tell them.
Yeah, because all of our paramedics, they're good. They're not trained in that. So that was actually an physician equipped ambulance that came to the scene. Very experienced pre-hospital guy.
And obviously his thought was the same as your thought. This is a massive pulmonary embolism, or it could be some cardiac whatever. But anyway, that would be it would be correct to give her some antithrombotic. She got Metalysa and heparin. And as he saw with the ultrasound that he expected this to be a pulmonary embolism. And then they used the CPR device, the Lucas device. Is that known to everyone? So one of these mechanical CPR. And they are quite strong. And then she had a return of spontaneous circulation after 35 minutes on the way to hospital. When she arrives in hospital, she's intubated. She has respiratory rate of 16, equal breath sounds, sats with oxygen. She has, not on a mask, she's intubated, sorry. She's pale, warm and dry skin, systolic blood pressure of 88, pulse rate of 80, but it was 35 on scene or during transportation, and it was 120 when she arrived, and then so it's fluctuating. And she has a temperature of 35.4, normal configuration of her abdomen. What would you think? I'll go back to this. So you're there. So there's the team of sort of medical team, and there is at least in our hospital the sort of the trauma team, the surgical team is also activated. What do you think? What would be how would you resuscitate her? Would you have an opinion of it on it, or is this just medical and let it take her to?
The reality is, by us, she would have been seen in the ED. Our pre-hospital personnel would have been the ones initiating the CPR, not a anesthetist-driven type of resuscitation. The ED doctor would have seen her, would have initiated already, placed the central line, initiated inotropes, placed the A line so that we can connect it to some form of arterial tracing. And she probably would have been seen as a medical patient, and the trauma team wouldn't have been activated at all.
But she's not doing so circulation wise, she's not doing very well. Would you give her anything but inotropes? Would you give her any kind of fluids?
I don't see that she's volume depleted. So I would also do, when you look at the fast, just briefly at her IVC, I would see if there's any signs of compressibility, give an idea about her preload and her fluid status. Before I would just resuscitate her, and I'd get an ABG first before I would decide on fluid management. This is what we're dealing is, because this doesn't seem hypovolemic shock. This sounds very much like some form of cardiogenic shock. Well, that's initially what I would have thought, pending further investigations.
Any other comments on that? The rest of you agree? Okay, so EKG did not show any kind of ischemia. She was, like you said, she was seen by, she would send an echo. Hypovolemic, definitely, but elevated filling pressures on the right side. So she was seen as hypovolemic, but with the pulmonary embolism suspicion. No pericardial fluid, and her blood gas with a lactate of 13. And you have the PO2 and PCO2. They're quite she has more than enough. So PO2 is elevated on ventilator. Her PCO2 is fine. pH.
The pH was 6.9.
Sorry, it was 7.
Yeah.
Sorry.
6.9.
Yeah. Is someone performing any fast?
Yes, it was. So fast was done, and she has blood in her. So she has fluid in her abdomen. Pericardial, she had no pericardial fluid, but she has abdominal fluid. Now what?
Yes.
What will you give her? Only vasopressors or blood products, coagulation factors with the pulmonary embolism?
Yeah, so this is something that I have unfortunately seen a couple of times when they put the Lucas a little bit too low. And obviously, that's a concern at this point. If you have a fast at our place, the trauma team wouldn't be activated on this patient in the initial management. But if you are there, you see the Lucas is misplaced, and you have an ultrasound that shows blood or fluid in the abdomen. I would probably start to give her blood.
The Lucas was not displaced; it was absolutely well placed. That doesn't exclude the possibility for a liver injury. I think I think you make a point, really a valid point. We see that once in a while that they actually, and we actually have that as part of our protocol, that they have to be checked after they have recovered their circulation. They are checked for blood in the abdomen, basically.
My I ask to the panelists, how many of you that would you have the trauma team activated? I know Shaheen would have been activated. What about Oslo and?
No, I wouldn't have been activated.
You would have not, right? You would have not.
Yes.
This patient has come in as what would be classified as a medical emergency, as a medical
Exactly.
patient, and there would be no indication for involving the trauma team.
Mm-hmm.
Now, we know, because this is about liver injuries, that we can probably work out where this is going and what's happened. But without that sort of benefit, you've still got to wait to prove that there is a trauma here. Although that's very likely, given what Shaheen said, that's what we'll find.
Yeah. But I think the point is that in this situation, in our setting also, it's a medical patient. Absolutely, it's a medical patient. But they suspected as much, and she was anticoagulated in the pre-hospital setting. So they suspected her to be hypovolemic so the gut feeling of the pre-hospital anesthetist who came in with her that this was something, and then they activate whatever they feel is necessary. So this is not normal in our setting either, that we all are activated with the medical situation. But what would you do then? So if you are activated, they do suspect there is blood in the abdomen, or at least fluid in a young woman, that's blood in this setting. Well, what would you think? Would you give her TXA with her pulmonary embolism? She's now fully anticoagulated. Would you give her fibrinogen? Would you give her 1:1:1 massive transfusion? Would you warm her after her cardiac arrest? Tricky. More heparin? CT scan? Coronary angiography? What sequence?
So it depends, in my opinion, on hemodynamics.
Mm-hmm.
If the patient allow you to get a CT,
Mm-hmm.
it would be good. It depends, as always, about on resources, physiology, because probably there is a lesion that could be a lesion on the liver.
Yeah.
An adenoma, a ruptular adenoma, because she was nowadays is quite rare, but female with the contraceptives could have an adenoma that rupture after. You could have a spleen injury too.
Sure.
So you have to rule out. If the patient allow you, you can even imagine to treat it by interventional radiology, counteracting. So trying to improve the coagulation system, which is a very difficult situation because you need to thrombolize, but on the opposite side, you need to coagulate. So
well, you can, yeah.
Based on the information so far, Tina, you suspect that she had cardiac arrest secondary to pulmonary embolism, and based on that, a CT scan, if the patient can tolerate that, is indicated.
The other question, yes, just a question for you before you get the word, Hayato. Do you know if your hospitals have the availability, interventional radiology, to actually suck out thrombuses?
Yes.
Yeah. So that would be a reason also to get this mapped with the CT scan if the patient tolerates it.
Yeah, actually, we still do not understand if the hemodynamic instability of this patient is coming from the heart or from the bleeding, right?
No, but what you know is that she has a significant amount of fluid in her abdomen. She has
from the EFA, right?
Hypovolemia. She's seen as hypovolemic from an echocardiography on the one side and challenged on the other side. That's what we know. So we really suspect her to have a pulmonary embolism. We really suspect her to have a bleeding in the abdomen, and that's what we know at the moment. And we do actually start with plasma, and so 1:1 resuscitation. But
I think I would start with resuscitation and would activate my massive transfusion protocol, and then I would go to CT scan, because we need a strategy, because the strategy could be to have an interventional radiologist to embolize the liver, but we also have to consider that she does have a pulmonary embolism, and they might aspirate it.
So that's what they saw. I don't have all the slides with the pulmonary embolism, but she had central pulmonary embolism, absolutely, and she has this abdomen with blood. And if you see the liver on that side, it looks a bit weird, but she does have blood lying along her right lobe, so a subcapsular, but lots of free fluid as well, all the way down to the pelvis. You see this
really looks like from a Lucas, right? With that kind of hematoma.
Yes.
Glyconia hematoma.
So this is what you have now. And so the question is, again, like you said, do we take her? So the interventional radiology is now waiting.
Do we have a hybrid room?
Yeah, we go to the hybrid
So that's if you have a hybrid room, that's okay. What about if you do not have a hybrid room?
That is my question for you guys. The ones who don't, I mean, we're lucky. We have a hybrid room. We can say to our interventional radiologist, we can decide together with them. We want you to start by sucking out thrombosis if her hemodynamics will tolerate that, or start to do an angiography of her liver. And we can open the appendix if we need to do that. But what about the fact if you don't have that hybrid room?
Before we go on with that discussion, we could give some more information from the CT scan, actually, because this is this is a combined phase. So actually, in the pure arterial phase, we didn't see any extravasation close to the liver, but this is actually a portovenous phase, and then you have this contrast close to the liver surface, indicating that this is not an arterial bleeding. This is actually bleeding from liver veins or the portovenous system.
Shaheen, you have your hand up? Or is it
actually, it was a couple of slides back. To start with, most of our hospitals are not built for patients that come in hypotensive. We have this hybrid ER in Örebro since this year. So this patient would have got a CT light immediately when she walked in the door. So the question becomes, should we take her to the CT or not? In most instances, the patient need that CT for this information. Obviously, you got it here, and
it's necessary.
Yeah, it's necessary because I cannot overemphasize how important this is in this kind of patient population where anything can go on in their belly or in the thorax or wherever. And for your question, for those who doesn't have hybrid rooms, fortunately, we both have the hybrid rooms and we do have the endovascular capacity to suck the thrombosis out. For those who doesn't have it, it's like Mauro pointed out, it's walking the line and hoping for the best. So this patient obviously needs to be operated on because that much of blood and already being getting the thrombolysis, somehow you have to go in there and do your best with whatever you have.
Christina, Vicky, any comments?
Well, in my place, we have an hybrid room, but unfortunately, it's not always available. It's most of the time it's in use for other specialties. So it's something I will face in a day. Probably I will go to the OR, pack, and try to quickly move to the angio suite with a laparotomy. I'm more afraid from the bleeding source than after that we can remove the thrombus or whatever. But I will not feel comfortable if I go back to the angio suite before packing the liver.
Yeah, but once again, for those of you who have operated on patients that have been on thrombolytic or on ECMO, they bleed. Saying that we go in and pack, I'm not sure how much that's going to help. I would probably cement the liver with flow seal, taco seal, or whatever we have on the shelf. But even with that, it's, do your best.
But this patient is going to be anticoagulated anyway, even if you are. So I think that's probably. I don't see an active bleeding from. Or can we say there is an active bleeding on the CT?
There is a venous bleeding, but no arterial from the different phases.
So this patient has to be under anticoagulant for quite a long time, and I think we have at least 2 liters at least of blood in the abdomen. So probably I would go to the OR with this patient.
The thing is that maybe if you go to the angio suite, you are not going to face anything to embolize in the liver. So
the question, may I ask, what do you think? Do you think the patient will die early before, early due to the bleeding or to the pulmonary embolism?
Yeah,
First of all. Secondly, as Jonathan told about, this is a medical emergency. So activation of trauma team is quite particular. You were lucky. So the patient, the female was lucky because went to the Oslo University Hospital with a very proficient trauma team. But in general, this kind of patient are admitted to any emergency department where trauma team is not always established during the night, with only maybe one surgeon or two surgeons there, because it's a medical emergency. And so I think that, in my opinion, this patient should go. If you don't have all the facilities you told about, this patient has probably exactly more than 1.5 liters, 2 liters in the abdomen. The moment I saw this kind of situation, if I have to activate my interventional radiologist, it takes time. Probably it's better to stop the bleed and then go ahead, already knowing that the patient had quite surely. We don't have the map of the thrombus in the pulmonary artery, but we know that right chambers were dilated, so all the diagnosis is quite done.
Okay, Vicky, you had a comment?
Yes, so I must say I agree with the above. I do think if you operate in isolation without managing your medical bleed, because she has been thrombolized, you're not going to, no amount of suturing is going to stop a medical bleed if you don't have the correct factors or platelets or whatever the impaired system is. So I would run a TEG for while I resuscitate her, pretty much with a 1-to-1-to-1 protocol. I would take her to theatre. I would cell save the blood. I would pack the liver, because I prefer to have a live patient that has respiratory and cardiac issues than a dead patient that you never start with.
Yeah. I think what you all describe, I mean, based on different settings, and obviously, I mean, you have to be there with the patient to see how the patient responds to the situation. But what you're all describing is the headache between this really, really bad schizophrenic situation where you need to anticoagulate her and you have a bleeding and so on. Anyway, she got the CT scan you saw, and she didn't tolerate that too well. She had already started her 1-to-1 based on the fast on the way to CT scan. Her lactate was down from 13.3 to 9.8. Her first fibrinogen came back 0.6, and discussion was, are we going to pour fibrinogen on her with that thrombus, or are we just going to, and then what? And we had that discussion now. She went to the hybrid room. The interventional radiologist started with aspiration. There was no findings of, while there was an observation, if we hadn't had that hybrid room, we would have had to open her like you all described. But standing there and seeing how she actually was reacting, and they were looking at this relatively quickly, and we said, okay, the hemodynamics were worsening, and she ended up with laparotomy, 4 liters of blood in that abdomen. The liver got packed, and total, because she continued needing transfusions over that day and night. I mean, she was fully anticoagulated. That was her total transfusions. Well, I could just jump the VAC. So when do we take her back? How long would we wait to take her back? And do we just sort of unpack, leave drains? What would we do?
You mean
yeah.
You mean the pack works? And
yes.
Okay, so
obviously, yeah.
Okay.
Yes.
I will do not leave any drain, and I just do a Barker laparostomy, and maybe 48 hours. Yeah.
After that, when you come back after 48 hours.
Yeah. Okay.
Second look.
Yeah, on the relook. Would you leave a drain then? This is the picture of her her whole capsule on the right liver lobe was lifted off her basically, and there was a hole in the lower part where the blood had come out. So we actually don't know what part of the liver surface she had been bleeding from, but she was easy to pack actually. So could have done that probably half an hour before and saved at least a liter of blood probably. So that's the backside of having the hybrid room, and you get tempted to try to solve it, and you cannot when that woman is totally anticoagulated. Anyway, she was anticoagulated from day 0. She had got the pneumonia in the course. She was extubated on day 5, and she has full recovery with her head in place, normal and unchanged. CPR, what can cause abdominal injuries, and I think that's the reminder, I think, and we have a protocol where we catch those. Well, so the CPRs where they have so we have made them more aware that they should ask for an ultrasound or to see afterwards whether there is bleeding if the patient doesn't behave as expected after return of spontaneous circulation. Lucas is more at risk than normal CPR, obviously, rare combination with pulmonary embolism. So, yeah, anyway, the fact that a multidisciplinary team and the fact that you have to consider other aspects of the resuscitation in the situation where you have massive thrombosis is also part of that. Okay, now we have 22 minutes for 3 cases. So that means so this is a 25-year-old man. We have no idea when it happened, but he was found on the street, time unknown, language issue. So we actually didn't get the full story of what had happened, but there was a hole in his right posterior chest or back, basically. Hemodynamically normal-ish, awake, breathing spontaneously, and he was taken to hospital without further anything. He was just not far away from the trauma center. No color, trachea midline, reduced air entry on the right side, sat down to 91, blood pressure 150, pulse rate 100, pulses palpable also peripherally, normal pulse, normal D, and log roll, apart from the fact that he had a hole in his back, was normal. No other holes, basically. Fast or chest X-ray?
Both.
Both. Yeah. Okay. Fast abdomen, pericardium, and if you want the chest X-ray, you don't want to go with Shaheen. Do you only want fast or no chest X-ray?
Well, once again, I don't see the necessity of doing the chest X-ray if you do the fast.
Okay. Can I challenge you on this one?
Yeah, Shaheen's patient is already in CT scan.
Exactly.
Okay, this is the chest X-ray.
Okay.
Okay.
Is he still stable?
He's doing okay.
Mm-hmm.
Then take him to the CT. Obviously, we have the CT close by. So and I see Vicky got a little bit shot there. He's stable. You don't know how much blood there is. Get that CT, then decide.
You want the CT scan before a chest tube?
Yeah, because there are data coming out right now also with the pigtail or the big chest tube. Chest X-ray for me is out. The reading on them, the patient on the back. This is a very tiny patient, but if they are large enough, they don't say anything. If he's unstable, he's going to get the chest tube. If he's stable, he's going to go to the CT, and we take it from there.
Well, actually, I do not agree with Shaheen. I would have my EFAST. I could detect some fluid in the chest, probably, right?
Mm-hmm. Sure,
and then I would have my chest X-ray to check the chest tube or go to CT scan.
But I think Tina is now asking based on what you can see on the chest X-ray. What
So I would have gotten a drain straight away. So for me, that is, I hope that's a bullet marker or that paper clip is over the stab wound, which looks really. So yeah, about 6 intercostal space. So I'd like to know what he was stabbed with, but the patient won't know. And he would have had a immediate intercostal drain followed by a post-insertion chest X-ray to see if it's adequately drained or not. And only then would we have decided on whether or not the patient gets to have a CT, because
Does anyone
limited resources, and B, the amount of millisieverts that you're exposing to the patient to in a year.
What we did was actually we wanted a lateral view.
But we want to, can we ask you, don't you react to anything on this image?
Oh, yes. What?
Really?
He still has a blade inside,
Aha.
isn't he?
Okay, I thought that was something you put on there just because showing the tract.
That's not a bullet marker.
Okay.
That's not a bullet marker.
Okay.
So I would like to have a lateral X-ray.
In that case, I changed my answer to put in a large drain.
Can anyone tell me that this X-ray is not useful? Vicky is really laughing. Why are you laughing?
I'm enjoying this so much, I have to admit, because this is so typical Barrow patients.
I know. That's why I'm saying, why didn't you comment on that immediately? Okay.
Be a type of Norwegian or Finnish type of bullet markers that you guys have that we don't have.
Yeah, we have a different type of bullet markers. Okay. So what else? So before you go, you said you wanted a chest tube.
Yeah, I would place a chest tube. I would do a fast for him. If he becomes unstable at any time, he's going to get well, if it's the blood's in his abdomen, I'm going to probably start with a laparotomy, in all honesty, because usually he's spontaneously breathing. He'll suck up all the blood from his liver going into his chest, and then decide if I need a thoracotomy or not.
Okay, so his fast abdomen is negative.
Okay, good.
His fast pericardium is negative. That's also good, right? So now we are there with the chest tube on that side. Do you want any other X-rays?
A lateral.
Yeah, okay, thank you. Wait, I'll give you to you. Actually, this is on his, he's actually prone. You see the blade there? I'll give you a better view in a few seconds. Okay.
I forgot this was a webinar on liver injury, right?
Yeah. So the story was actually that his brother had stabbed him in his back with a kitchen knife, and the knife had broken. So one of the points is don't stick your fingers in any holes, guys. You have no idea what's inside. Anyway, the chest tube came out with 750 milliliters and it stopped. His blood gas, you see it where it is. And he's doing fine. After he was actually given just ringers. He was doing fine. He was just after a few hundred milliliters, no transfusions, normalizing lactate. Would you want, so I heard your approach, Vicky. Obviously you need to would it be useful with a CT scan if this patient is completely normal?
Yeah, I would definitely scan him. You need to see where that blade's going. You need to visualize the liver. You're going to have to take that thing out at some point of time. And I wish all of us good luck in doing that. And even now with the newer generation CT scans, even the scatter that you're going to pick up from a metallic object, you can often subtract to make sure there's no active contrast extravasation, and do it under vision.
I think the point was here to actually challenge the old saying that we can't do CT scans because of all the scattering. And I agree. The point is you actually do get a lot of information if the patient tolerates it, and if it does change your management. And this patient, actually, you would want to know where it is. I think just looking at looking at where it sits, you would want to know where it is. So how far is it from the IVC, the liver veins, and everything else before you pull it out? And does it actually go through the liver or not? And so on. Anyway, but you said it. This needs to come out. There is no doubt. You can't leave that as a bullet. And then the operative approach is something that this guy actually allows you to think about because he's doing fine hemodynamically. So you can actually think what is the sort of. This is actually just the scout from the CT scan. This is the equivalent of the Lodox, but in a CT scanner. So now you see that. And actually, when you did the full CT scan, it actually stops. It doesn't go through the whole liver. So there's no way you can pull it out from below. So you have to pull it out from above. And that's not easy. It has to back out where it came in, basically. That's the blade, basically. So he was supine, access to the stab wound, and he got like you said, he had to go into the abdomen. The knife was outside the bare area. It was backed out through the stab wound with a small, enlarging of the chest stab under very controlled. And then the diaphragm on that side was repaired, and that's obviously because you don't want it to bleed up through that into the, even if, like you commented on right-sided diaphragmatic injuries. This one is not going to have any other problems apart from the fact that you can leak a lot of bile through it and so on and so forth. It's actually nice to get it closed. And then there was small ooze. There was full control of the liver when it was pulled out. Not massive bleeding. So some flow seal, tacho seal. And then abdomen was closed. And then his chest was closed. Drain was left. He was discharged on day 6, and then he was readmitted on day 8 with pain and falling hemoglobin. What do you want now?
As always, CT scan.
Yeah, well, now I agree with you, Shaheen. I absolutely agree with you. Okay, this is what you get. So he has a little bit parallel to the other one, but what you find now is a big pseudoaneurysm in the channel through the liver. Then what you want to do?
And no fluid in the chest.
No fluid in the chest because the diaphragm was closed.
Obviously, if you have the angio capacity, just coil that.
Yep. So that's what was done. And then he was discharged on day 15. No symptoms after 2 months. So again, no fingers in wounds. That was actually the main unexpected. You have time to plan if hemodynamics allow you to, and sometimes it has to be a little bit maybe improvised. And sometimes you don't actually have a roadmap from before. And then you need to follow these patients, or at least let them come back if something is wrong. I think that's most important. Okay, and just another case. This is winter. We are actually approaching winter. 46-year-old man, ski jump, fall 3 meters, pain in the right chest, dyspnea, IV lines, oxygen, immobilized, and taken to the closest hospital. And this is a hospital with trauma receiving capability, not a trauma center. And the report from that hospital is that the guy was awake. He had reduced air entry of the right side, respiratory rate of 23, suspected rupture of right diaphragm on x-rays. A right chest tube was inserted with 350 milliliters of blood coming out. Blood pressure 100/60, pulse rate of 120. He got 1 FFP and he's normalizing on that with the lactate of 1.8. He had pelvic rami, but not an unstable pelvis, and he had the right humerus fracture. And they want to send him to the trauma center. And it's about half an hour helicopter. Right. What do you say? Do you need more information? What would you tell them when they call you? If you are the trauma center, they call you and they say, "This is the guy. We are worried about his liver. He has a diaphragmatic injury. Do you want us to do a CT scan? Should we send him like he is? He's awake."
How did they actually suspect that he had the right diaphragmatic rupture?
They said that they had a heightened
Capping of the liver. Capping of the liver.
Yeah. That was well. At least they said that the radiologists had said that they suspected there's a right-sided diaphragmatic injury.
No bowels in the right chest.
No. So it's the liver that's herniated. Are you happy with that?
I would have probably said just to send the patient. It depends on where we are, but you also don't want them, whatever they must do, they must rather get the patient to you as quick as possible. So it is a pretty long flight, but I wouldn't want them to delay doing investigations in a place where they cannot manage it. So I don't know exactly how much this hospital specifically could or couldn't do. But if somebody phoned me and wanting to transfer this patient, I would say you can do whatever you feel necessary at the point in time, but it should not delay transfer to definitive care.
Exactly. I think that's part of how our trauma system is built. But all those hospitals, they have the capability of doing damage control when they have to, but this guy doesn't tell them he has to. And it's not that far away, and the transportation was readily available. So they decided to do that. Okay, but so he's now 4 hours after the injury. He's arrived. He's awake. Trachea is midline. Well, still doing the same. Pulse rate 120, BP 110. So he's got 2 units of plasma basically. That's his X-ray. Yeah. What do you think? That's a scary. That's a scary.
Yeah.
Okay. Any of you? So that is my. So my question is: would you have a CT scan in this guy before you operate on him?
No,
He needs an operation.
Are we lucky that he actually arrived alive?
Yes.
If you had been sent this X-ray from that local hospital, would you have said you're happy for them to transport him by helicopter awake?
He would die.
Well, they did. They did transfer him by helicopter alive. He's still
Oh,
alive.
yeah.
He was
did.
lucky. Could they have killed him by doing anything but transport him by helicopter?
Well, it's a very strong guy.
It's a
The
very
only thing is I'm
it's a very scary-
surprised.
Say again.
Because I'm surprised he is as stable as he is, because his entire mediastinum is shifted over to the one side. I mean, his cardiac preload will be minimal.
Yes.
So I'm surprised, pleasantly so, that he survived and he made it to the other side. That is really concerning.
What actually happened is that his liver is probably herniated at the moment of the injury, and since then nothing more has changed. It's not an increasing hematoma. It's not a bleeding in his right chest. That's the reason why he has been tolerating this so very well.
I think
we
were
need
actually,
an operation, yes, for sure.
I think we were actually lucky. We were really scared when we saw this picture, and we said we were actually lucky not having seen the picture before they transported him. We could have told them that they should intubate him or do something that would have changed something and would probably have been really bad for him.
Yes? we have over 100 participants this time, which is very good. And many of them are probably residents or medical students at different levels. You could probably point out what we're talking about so they can follow us on that X-ray, what we see that we shouldn't see.
So first of all, the one point is trachea midline doesn't mean a shit, basically, because it's always midline until the patient is okay in the neck, and that's what you see when you do your primary survey. Anyway, his trachea lower down is really deviated. His liver is up here, so the whole liver is probably herniated into his chest, and that pushes his. That pushes his whole mediastinum with his heart over to the right, to the left. From the right to the left, and that means his mediastinum and his heart is really compromised. This is what we call not tension pneumothorax, but tension hepatothorax. That's another version. Anyway. They had a binder on for some reason. You see he had some rami fractures, but nothing major in his pelvis. His fast, there was nothing much. His lactate was 2.2 when he arrived. So you decided that you're not going to to delay this more already. Obviously, there's a risk with the intubation, so you have to be really ready when he's intubated, and then get repositioning of the liver and compression of any liver injury. We don't know if he has a liver injury because we haven't got a CT scan, and then repair that diaphragm needs repair. There's no doubt. And then chest tubes, obviously, and then whatever. So this is after the repositioning of his liver. His whole liver was up, and the diaphragm was lying under his liver. So the whole liver was up, basically. Liver. So any diaphragmatic injury, however bad it looks, can be closed. There is from below. Yes.
As far as I remember, we had actually to enlarge the defect in the diaphragm to easily to be able to reposition the liver into the abdominal cavity, which is actually a trick that you should remember.
Yep. Okay, so this guy then, he's not bleeding from that liver after you repositioned it. You can't see, it actually looks like this liver you see here. So it looks fine. There's no bleeding when you let go of it. You don't have to push on the IVC or anything. Do you close it? Do we leave him open with the back until we have a CT scan of his liver? Vicky says we close him.
I will also close this patient if it's dry inside.
Yep.
Yeah.
Okay. Any against? Can we
in favor?
All in favor. Okay. So he got closed, and this is the CT scan after. So this is the cracks behind. We did leave a drain basically after, so just to see if there was something. So he was extubated. He got an epidural, same aggressive thromboprophylaxis, nutrition mobilization. Humerus was operated on day 4, ward day 5, local hospital day 10, and it went well basically. So tension hepatothorax. I think I've never seen worse right-sided. So completely herniated liver without more injury was lucky for him. And intubation risk in that setting. So any tension, whether it's the hemothorax or the gastrothorax with the ventricle inside or the liver, I think it's something we have to remember. The last case, Jonathan, you allow me 3 minutes? 3 minutes.
But you don't do it in 3. But go on.
Yeah.
Tina
and team, I have to run to another meeting.
Yeah.
It was really nice cases, Tina. Great, and nice to see you all.
And great input from you.
Okay.
Good.
Thank you.
Good value.
Cheers.
Okay, so this one is also relatively exotic. This is the typical Norwegian winter fun. Is when they go on a plastic bag. Many youngsters on the same plastic bag, no control. Could be with or without alcohol before, depending on age. But anyway, there are lots of branches and trees in those pists, which is not always good. So this is a 22-year-old woman, and she's in front of one of these things, and she gets a penetrating perineal injury from a tree branch. And then, well, she knows that there was something hit her, but it wasn't impaled or anything. It's just pain locally, and she was her symptoms was, or her physiology was taken to the local hospital. What would you do in a situation? She has a penetration in her perineum. This was high speed. It was a branch. We have no idea how it looked because it was it hits her and the thing continues and it was ripped out again basically. So what do we do?
CT scan. You have 3 minutes, Tina.
Okay, CT scan of what?
Abdomen.
On the abdomen?
You will probably take, at least in our institution, is a chest X-ray. When she came in, you get that for free, so to say. So if you see anything wrong within the chest, you would actually include that as well.
So that's local hospital. They saw that she has a pelvic problem, so she did take a CT scan, but only on her pelvis. Okay, so you see that there's air and there's some fuzzy things in the seat, so it doesn't look good. There's something going on there without much. Anyway, I'll just run through that. So they thought, okay, this is not good. So they did a diagnostic laparoscopy, and they did drainage and some washout and put on antibiotics. On day 4, she is spiking temperature and she's peritonitic. So now she gets her full CT scan. And this is her full CT scan on day 4, 22-year-old. What do you see?
Liver injury. Why do they perform? Is that because of cost saving that they had just a lower abdomen?
No imagination. I think that this could actually go so far. We have another case actually a few weeks before or after that went up into the left chest and stopped on the 6th rib. So I think the whole point is to do the full torso when you have something like that, definitely. And now she was transferred and she was opened, and actually we found bark from the tree in her abdomen. So that was taken out, and she got to drain for bile leak. There was no bleeding from her liver, and then she had the reconstruction of her partial sphincter injury, and then at 4 weeks she had to do a relap for bowel obstruction because of adhesions, but then later on full recovery. A full functional recovery as well.
She had no bowel injuries.
No. So it just went between and up through the liver, basically, and lucky. Same as the other one, actually. That was also lucky, and no. So perineal impalement are rare, but to be paranoid and actually think that this can go through several cavities, even if the patient is doing fine. And this is a trauma center task, and it could be transferred. And again, expect the unexpected. And that is my last slide for the last case. And we are reminding you about the Congress in Ljubljana in May. It's going to be a nice time a nice time of the year. So we hope more are going to join us there. Yeah. Thanks, Jonathan, for patience.
Thank you.
Waiting. And thanks to the panelists and to anyone who has been logging on. It was great. I think we got a lot of points, a lot of messages through these discussions.
Thank you very much, Tina. Just to let you know that many friends of yours, of our friends, were connected. Like David Zonis was connected. Chino Bentinelli from Australia was connected. So a lot of Antonio Lagreca from Rome was connected. So it's nice that we since Shaheen just said that probably we had many residents actually connected. We had the very head of departments and a lot of guys with academic position, and so that's very nice, I think.
Some of them should have been on the panel, but weren't sure to be here. But we will challenge them on later webinars.
Right.
And all of them will have benefited from your explanation of that chest radiograph, Tina. I'll take the opportunity to thank everybody again for organising and taking part in this evening's webinar. I hope you've enjoyed it. We have another webinar in 2 weeks with a different panel, which will be looking at surgical management of open fractures of the lower extremity, something completely different. So I hope this has been useful. I hope you've enjoyed it as much as I have. Thank you very much, and look forward to joining you in a couple of weeks' time.
Bye-bye. Thank you.
Bye.
Thank you, everyone.
Thank you.
Thank you.